So what the heck is building information model? We usually call it a BIM, and this is my favorite definition. It's from Chuck Eastman at Georgia Tech. It's a modeling technology and associated set of processes. That's in yellow because I think it's important. It's not just the 3D model, but it's what we're actually doing around it to collect data, implement data, to produce, communicate, and analyze. And again, that's not all that important, but it's building models. So that's what we're looking at. So what do these things look like in sort of real life? So BIMs are becoming increasingly accurate. So this is a structural wall that actually does really well in earthquakes, but that would be a different presentation, so I won't bore you with the details. This is what the wall looks like in real life. This is what the wall looks like in 2D, and this is what the wall looks like in a building information model. So hopefully they all look very similar to you, and you're like, oh yeah, okay, I get it. The 2D looks worse than the 3D, which looks worse than the reality. So that's sort of what I'm hoping that you'll pick up on. And not only are we able to do things like that, but this is a rendering of a full building in a different software. So I want to be a little software agnostic here. I think usually people think BIM, they think Revit. And actually I don't have a single shot of Revit in my presentation because when I think BIM, I don't think Revit. So this is a different model, and this is what we call a geometry model. And then right behind it is the energy model. So you can see that we're getting pretty good at actually replicating with our models what real life looks like. This building isn't actually finished being constructed yet, so I don't have a real life picture. But it's becoming more and more accurate to model things and then see them sort of in real life. And perhaps more importantly, the models themselves are becoming more and more similar as we build them. So why are we even looking at this? Why do we even care about this? And so building information models, as the name suggests, they have information in them. And traditionally that's thought of as information about the physical artifact. So how big is this piece of steel, or how large does that pipe need to be? And that's great information, and it helps us to construct and to know what we're going to have in the building. But other places are using all sorts of other data streams and all sorts of other pieces of information to make things better. So I think a good example of this is, I don't know how many of you are Safeway shoppers. I live in Arizona, and this is a place that we use. And they now track what you buy, and based on what you buy, they offer you special coupons. So this is a neat thing. And now they're starting to take these ideas about what people buy most often and actually feed these into the design of new Safeways. So they know, like, oh, actually, the refrigerator section gets a ton of money in Arizona, so let's add another refrigerator aisle. Pretty cool. Wouldn't have thought to do that if we weren't tracking exactly what different consumers buy. And as you can imagine, this varies across the country, across demographics, across social and economic boundaries, but essentially this is data that we use to get better. So in a healthcare setting, what does this mean? What does this look like? Well, if most people are coming to us with a surgical need, maybe we want to increase the number of surgical rooms that we have. If most people are coming to us and saying, I have a cold and I just need a quick outpatient visit, then maybe we want to increase the number of kind of minute clinic type of space that we have in our hospital. And also importantly, we want to look at the negative things that are happening in our hospitals along the lines of infection and dust and other issues, and try to mitigate those. So not only are we trying to improve our ability to service these positive things, but reduce the negative. So there's a ton of existing data streams that are tracked. I'm happy to have followed Cassie, who showed you that lovely subset of the metrics that are collected for every hospital in the United States. And medical facilities don't have quite that extensive of reporting, but they also have some. So here's just a snapshot of existing data streams for hospitals. I won't go through all of them, but they are, when you ask people, what do you track? These are the things that they say, and the things that are really big are the things that they really care about. So patient information is the first thing out of everyone's mouth, and that has a ton of data associated with it. The cost of care is another huge thing that comes out of people's mouths. So energy metering, this is becoming bigger and bigger. And what people are doing, and then indoor air quality is a major driver for medical care. So these are things that people are already tracking, and so these data streams exist, but somehow it doesn't seem like we're actually getting better at designing. So in the example that Cassie just presented, we have a new hospital, it's larger, it has these green features, which is fantastic, and there's probably some thought, or maybe a lot of thought into the care, but you didn't see or necessarily hear about the fact that they figured out our most common consumer here needs these 3 things, and so we're going to design most of our space to meet those 3 needs. So the other thing that's, I think, fairly unique about healthcare systems compared to other buildings like a mall or a school is that you have this pretty tightly woven set of interdependencies. So I don't really love PowerPoint graphics just off the shelf, but I think that this one does an okay job of expressing what I'm saying. So you have healthcare providers who are bound by regulations, and this is what I thought was interesting is this is the way that healthcare providers explain it to me. So they don't actually feel that they have a direct connection with the patient experience. They feel that they have a direct connection with the regulation, which tells them how they're able to address the patient experience. So I thought that was an interesting finding that I would share, and that actually impacts quite a bit the way that hospitals are designed and delivered. So the idea here, or what I think we would all like to see happen, is that all of these data streams that they're already collecting start to formulate design options for us. So if we're looking at a new facility or retrofitting an existing facility, we look at multiple ways that we could do that. We kind of put them through this funnel approach where we start applying more and more constraints to the system. So one layer of data tells me that I'm in the desert, so I need a lot of air conditioning. The next level of data tells me that I have a lot of acute cases, so I need a lot of operating rooms, et cetera, and then eventually this final design spits out. In reality, hospitals are extremely expensive, so what generally happens is people say, design option 1, sounds good, let's do it. And then they build it, and it's not that no one thought about it, it's that they didn't have time or data required to actually think more holistically about what they were going to deliver. So this sort of gets to this. Why are we not using all these data streams already? Why aren't we doing this? If we collect them, how come we're not getting better at designing hospitals? So a task force was convened to talk about this, and this is what they sort of said. And again, the bigger the words, the more that it was said. So the biggest things were, there's no business case. So we can't share these data streams. We might track malpractice, but we can't relate that directly to the bloodstream infection metric. So therefore, I can't possibly say that bloodstream infections are something we need to address, and we need to think about making medical gases the same in every room, for instance. So they don't have the business case required to necessarily feed all this data in. There's ownership issues. If you're going to do a model and you're going to pass on this data, is that allowed? Does HIPAA let you? If HIPAA lets you, who's going to own it? Can the architect take this and then become better at designing Mayo, even though this was Banner's data? Does anyone feel okay about that? These things start to really come up. And then I think the other one that was a little surprising to me was that data interoperability is still a huge challenge. So they have all these data streams, but they're coming from disparate sources and coming, Cassie pointed this out, some of it's quarterly, some of it's yearly. So really taking it into and sort of molding it into something that a designer can use is a real challenge. And not only that, but the tools that designers use have no ability to sort of take this data in automatically, so it becomes a time issue. So we worked with the Alliance for Construction Excellence at Arizona State University to convene a task force to start addressing some of these issues. And basically, the big charge is, if Safeway can do it, there is no reason that a hospital can't. Safeway is full of people that are sort of working in these hourly jobs. Hospitals are full of people that have been to school for 8 years or more. There's no reason that they shouldn't get a facility that's actually designed for them if the sort of average consumer does. And more importantly, people are coming to hospitals expecting to have a critical need filled, not to get ice cream. Although sometimes you do get ice cream at the hospital, which is nice. But essentially, so what we're looking at here is an interdisciplinary team of experts. So the task force that we convened had someone from the CDC on it. It had designers, it had builders, it had healthcare providers, as in physicians, it had healthcare owners, facility managers, and actually building information modeling software producers, all kind of coming together to look at all these data streams and how could we actually start moving towards a more data-driven hospital design. So they said, well, here's the benefits that we think that exist if we do data-driven design. So the number one thing, and in this case, actually it looks bigger on my screen, but the better patient experience is becoming more and more important. So a patient-centric hospital design is becoming sort of the norm in the industry anyway, And the question is, are we really being as patient-centric as we can be, given that we have all these data points that we're not really feeding into our design process? Also, the fact that you could do better decision making if you start looking at ways that you can look at this data all the time and make it more visible. You can lower your insurance costs, that's both during construction and during hospital operation. You can go for lead points. There's all sorts of work around modular construction that we think that you'd be able to leverage if you start actually doing data-driven design, because you can understand which things have to be standard, and then those become good candidates for modularity, and some other issues. So what they've suggested is, this is what we really want to get to, and this was the sort of hallmark figure of our first task force meeting, and we are planning now to flesh this out a little bit more. What does this really look like going forward? So the first is going to be to develop this building information model that's very data rich. And the question is, what platform are we going to use? Will we have a platform that can take in all this data? Do we know where we're pulling all the data from? Have we worked out all the data issues to be allowed to share it with the designers? What's that going to look like? So this step alone, I think, will take quite a while, actually, to figure out what belongs in that BIM and how to deliver it. Prefabricate then, wherever possible. That would be the next step. And again, this is about efficient healthcare delivery. So this isn't delivering to the patient. This is delivering the physical facility. So there's a real desire to prefabricate. One of the biggest reasons for that at the moment is because it's standardized. So this improves both our construction time, and it's been shown to reduce negative outcomes in the hospital when everything's kind of happening. Medical gases are on the same side in every room, so nurses don't accidentally grab, I don't actually know medical gases, but we'll say nitrogen when they need to grab oxygen. I don't know, does that make sense, Cassie? You know, maybe you know more about these things than I do. There we go. Then the next thing to do would be to build a mock-up, an actual scale mock-up of these critical facilities within the overarching healthcare facility, and let people walk through it, give feedback, and allow that feedback to come back in to the building information model. And then finally do a full facility build. So one thing that's obviously missing from this is that there should be little feedback arrows, and I think that the reason that we took them out of this one is because the sort of holy grail is that you don't have to feedback, that you become so good at actually understanding your own data that when you develop the building information model, you get it right the whole time. So you build a mock-up and everyone says, this is exactly what I wanted. I'm so glad that you built me the perfect thing. We'll see if that ever happens, but we left the feedback arrows out for that very reason. And this is sort of pushing towards healthcare facilities of the future. So this is a mock-up of the new, or rendering of the new Mayo Clinic that's planned in Arizona. You can see the cacti, lovely. But these will be patient-centric, and so one of the things that you see immediately is that there's a lot more green space. Even in the desert there's green space, because there's a belief that actually is nicer than seeing brown space. So it's not just a natural view, but it's a green view, because the thoughts of the plants apparently actually have more of a healing effect than just looking at sand. So this is something that they're willing to make the investment in. And so lessons learned, the benefits largely outweighed the cost. If you're really into PowerPoint, you would see that the size of the text was bigger on the benefits one than on the barriers one. But even if not, that's okay. So the benefits far outweigh the cost. I think people are really excited about moving in this direction despite the documented difficulties. It's still really early, so one of the big issues still is going to be data formatting and whether or not the data can even be shared, but the idea lives on. And then new demands require new processes. So healthcare delivery is changing. They're looking at hybrid operating rooms where the physician isn't even sitting there. They're talking to a robot saying, okay, now move this, now move that. So that's going to just demand that we have new facilities and new processes that we think about. And that's part of why it's becoming so critical to collect all of these data streams, because what's worked in the past probably isn't going to continue to work from a facilities perspective, because our patient care and our actual healthcare delivery model is changing so much.